Hi everyone, this is GARCIA SIAM, and this is my discussion response to our topic for our DHA 736, physician preferences and treatment decisions. Healthcare delivery and outcomes are influenced by many factors, including end-of-life options. Some of these factors include healthcare coverage, like insurance, the type of insurance, and according to Cutler, patient demand is not as important in explaining healthcare variation as are the beliefs of physicians and organizational factors. Healthcare spending varies as much as double across different areas in the United States. So, what are some of the reasons why physician's preference might matter more than a patient's preference? Physician preferences have the potential in certain scenarios to matter more than patient preferences. One reason that a physician's preference might matter more is their strong belief in the efficacy of a particular therapy. If the physician communicates this strong belief in a specific therapy, the patient is more likely to accept, and therefore healthcare spending will base on that belief. A second reason that a physician's preference might matter more than a patient's preference involves organizational factors. According to Gruber and Owings, reimbursement rates on specific procedures can influence the decisions made by those doctors. For example, between 1970 and 1982, a 13.5 fall in fertility in the United States led OBGYNs to replace normal childbirth to a highly reimbursable C-section procedure. According to Cutler, organizational pressure and peer pressure to treat conditions a specific way also provide an explanation for a physician's preferences mattering more than patient preferences. And do I believe that the findings of Cutler's study could be generalized to other types of decisions? Why or why not? I do believe the findings of the study could be generalized to other types of care decisions. For example, in this study, researchers found that 35% of spending for end of life care and 12% of spending for heart attack patients was associated with physician beliefs and not supported by clinical evidence. In a separate study following the Medicare Prescription Drug Improvement and Modernization Act in 2003, cancer patients continued to have access to care, but the specific chemotherapy drugs that were used for treatment changed. According to Jacobson, doctors switched from the drugs that took the largest cuts in profit to high margin drugs. This is another example of the influence of organizational factors on physician preferences. There are policies that vary throughout the United States as well. For example, euthanasia is not legal at the federal level, but 10 states and Washington D.C. have medical aid in dying, whereas 40 states consider it illegal. So that would also be an organizational factor that would influence physician preferences and patient preferences. So what are the roles of supplier-induced demand and information asymmetry in physician preferences? Supplier-induced demand and information asymmetry influence physician preferences. Physicians are typically in a place to be the experts on a patient's condition unless the patient has equal or more knowledge. In this way, doctors can exploit information gaps to increase financial gains. According to a study, physicians can convince patients that they need unnecessary care. In addition, patients themselves can request unnecessary care because they have good insurance coverage. The lack of medical knowledge in combination with the trust in physicians can result in patients following medical advice regardless of the patient's preference. This next slide shows the references that I used for answering the questions for this week's discussion. I look forward to reading everyone else's in the class, and let me know if you have any questions about my responses.